Hello. Hello, everyone. Thank you so much for joining us today for this Stimulant Speed Sessions on Canada. Really pleased to have you joined us. Thank you firstly to the organizers of Constellations and of this panel for inviting myself and Dr. Andrea Serrata to have this discussion today. I should introduce myself first. My name is Nazli Maksudi, and I am with the Center on Drug Policy Evaluation. We support the development of evidence, health, and rights-based drug policies, particularly through research and outreach. We do so at the local, national, and international levels. I am based in so-called Toronto. I would like to first do a land acknowledgement before moving ahead with introducing Andrea. So I acknowledge that the land on which I live is the traditional territory of many nations, including the Mississaugas of the Credit, Anishinaabe, Chippewa, Haudenosaunee, and Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. So I'm really excited, really pleased to be in discussion with Dr. Andrea Serrata today. I'm going to be posing questions to her and offering some insights throughout as well. Thank you so much, Dr. Serrata, for being here. Let me give a bit of a brief introduction here. Dr. Andrea Serrata is a family physician working at the London Intercommunity Health Centre, where she focuses her practice on people who use drugs, people living in homelessness, and women involved in the survival sex trade. Dr. Serrata is the lead physician for the London Intercommunity Health Centre Safe Opioid Supply Program, which is currently the longest running safe opioid supply program in Canada. So our discussion today is, of course, about a safer supply of stimulants, but we both thought that it may be helpful to begin and understand the Canadian context by first speaking about a safer supply of opioids. We thought the audience might be a little bit more familiar with that, and it does as well serve a really useful comparison point for safer stimulants in Canada. So I'd love to bring Andrea onto the virtual stage here with me and pose a question. The first question for Andrea: can you please share your background and your experience as a prescriber of opioid and stimulant safer supply in Canada, as well as perhaps speak to what has happened in Canada with respect to the expansion of these harm reduction measures? Thank you so much.
Thanks so much for that welcome. And I have to say, I am so excited to be here at this conference. I think my harm reduction journey really started in earnest 5 or 6 years ago, and it was through this conference actually that I gained a lot of exposure that has actually really, taken my career down the path that it has. So I'm excited. Thank you. You did mention around, stimulant versus opioid safer supply. And certainly even in Canada where, as far as I'm aware, we have some of the more, robust, safer supply prescribing programs in the world. It's still predominantly opioids, right? And stimulant safer supply is a newer concept that a lot of us are bringing into our programs. But again, that experience is mostly in opioids. And really it started, at least for me and my team, in around 2015, 2016, when fentanyl actually became the predominant street-based opioid that was available to people in the street supply. And at that point, we were seeing so many deaths related to, overdose and infections and complications of, injection fentanyl use that we knew we had to do something different. We knew that the options available to people were not adequate. And we really reached something that we call in medicine, like a clinical equipoise moment where it was very uncertain about, we knew that there was this harm of doing nothing. We knew that we could offer this radical intervention, and the equipoise is, and where is the benefit going to come, right? And I think, pretty quickly, we saw really positive benefits to folks who are prescribed a safer supply, again, who could divert themselves from that street-based fentanyl supply, both in their health and their social outcomes. And so that approach expanded, right? And we started gaining more experience and developing our approaches of the prescribing of opioid safe supply. I think a key distinction around how that started in London and kind of how it rolled out in other parts of Canada as COVID came in 2020, I think it's an important distinction, right? In London, our program, again, was to divert people from fentanyl-based street supply. We had the development of something called the risk mitigation guidelines that started in British Columbia and were rolled out, I believe, in April or May of 2020, pretty soon after the pandemic started in March. And that was a little bit different, right? So risk mitigation, it still recognized that folks were at risk of all of these harms because of street supply, but it was COVID focused, right? So instead of the main objective being, helping people obtain a safer supply, it was how do we keep them safer from COVID through social distancing, through decreasing their need to be, on the street or accessing their drug dealer or whoever else they source their supply from, whatever that may be. And so that objective was a little bit different. And I think how we saw that roll out is a little bit different than how we do it in London, right? And it was really interesting to see kind of how that's developed over the past couple of years of the intersection of those two public health crises. But again, slightly different objectives and then slightly different evidence that's coming out of that. With stimulant safe supply, stimulant safer supply prescribing was actually formally recognized in those risk mitigation guidelines, which was amazing, right? And it really, I think, gave a lot of us the push to start incorporating that into our practices. Certainly here in London, that pushed us to start doing it a bit more. I would say it's still very much in its infancy, right? We don't have the same amount of experience or time behind that approach. So I think, I compare, if opioid safer supply is in its toddler years, stimulant safer supply, even in Canada, where I think we're pretty far ahead compared to a lot of jurisdictions, it's still in its newborn phase, or, maybe we're just sleeping through the night right now, but it's still early.
Thanks, Andrea. I think that's really, really helpful. And it really does show the different phases that the two are in. And I think that has a lot to do with how they've developed, as we'll talk about, and as well as the buy-in around them for their different respective reasons. But perhaps before we dig deeper, we can take a little bit of a step back here. We've been using the term safe supply and safer supply here. And I'm not sure if our audience is outside of Canada. And even in Canada, there tends to be some confusion about these terms, whether they're you can use them, they're synonymous, what the distinction is it just semantics? So I did want to take a moment to speak about that a little bit. So firstly, as Andrew was alluding to here, our federal government does use the term safer supply, and the way that they had defined it was providing prescribed medications as a safer alternative to the toxic illegal drug supply to people who are at high risk of overdose, right? So the focus was really that specific subpopulation at high risk of overdose receiving an alternative in order to displace what they are using that is toxic from the unregulated drug market. So very kind of clear overdose prevention impetus there. Now, in contrast, our Canadian Association of People Who Use Drugs in Canada, CAPUD, they have a different definition, and they opt to use safe supply, so dropping that R and using safe instead. So why this difference? Why safer versus safe? So certainly there are folks that would argue, I think policymakers would be in this camp, and why they've chosen to use safer, that the term safe is not appropriate because it's potentially misleading in that all drugs, even legal drugs, have risks associated with their use, right? So while it's true that the word safe could be misconstrued, CAPUD's position is that we really do need to recognize that this meaning is by way of comparison to unsafe drugs. And we can use analogies with very kind of simple things that are available, like a hammer and a nail that you can buy anywhere. It's easily accessible, it's legal. You could use that in an unsafe way. And everything, it has some sort of risk inherent to it, but that doesn't mean that we never use the term safe. Safe is always kind of relative to something that could be done more unsafely. And we recognize that there are still risks embedded with kind of all parts of life. So I think with quality of substances assured, as CAPUD articulates in their concept note around safe supply, that is putting individuals in a far better position to know the risks associated with their use and is therefore safe in comparison to an unsafe toxic supply. So I think folks can opt for a term that feels comfortable for them, but our government opts for safer, whereas I think community led by our Association of People Who Use Drugs opts for safe. Now, another really, really critical part of the CAPUD definition, which we will speak about as well, is that they are very explicit that safe supply includes for the purposes of euphoria. They actually say their definition of safe supply refers to a legal and regulated supply of drugs with mind and body altering properties that traditionally have been accessible only through the illicit drug market. So I think that's a key point of difference. And that's why they go on to say that substitution treatments, methadone, Solri's oral morphine, buprenorphine, Suboxone, these do not meet the criteria of safe supply because they do not contain those mind and body altering properties. So certainly those benefit people. And there are cases where safe supply can be used in combination with some of those substitution treatments, but those substitution treatments in and of themselves are not considered safe supply. Yeah, and I think another piece here, perhaps where our government definition and Kapud's definition does overlap, is this idea that it's meant to be lower barrier, right? Things like take-home doses being something that is permitted under that model, and attempting, at least in Kapud's view, more adamantly than our government's view, to avoid an over-medicalized model. They really do talk about how over-medicalizing or just too much of a clinical environment can turn off a lot of people who would otherwise participate in safe supply programming. And we'll talk a little bit about that too, perhaps during the Q&A, about what less medicalized models can look like. So I think that's a little bit about how the two definitions differ, maybe some of their overlaps on paper. Now, in reality, that part of the Canadian definition about highest risk, that population being prioritized, comes to play, right? There are some various examples, one of which I'll point to, which actually comes from a really great Filter online magazine that had written about an experience of an individual trying to seek safe supply in Ontario. And what they found is this kind of perverse incentivization of taking more risks, because they themselves were someone who historically had been a person who injects drugs. They'd made the decision to move to inhalation for their own kind of harm reduction reasons and decisions. And that they found that was moving them away from qualifying for safer supply in some jurisdictions. And of course, there's other requirements as well, right? Things like not having to had success on first-line treatments like methadone, buprenorphine, naloxone, in order to have access to things like diacetylmorphine or hydromorphone. And the fact that this system, it requires like failure on other treatments to get access to a treatment which may very well have been the best one for you from the get-go. So, of course, not to say it's very understandable that we have these conditions in place because there's limited capacity and there's so much need. So trying to be selective about those that are prioritized for these programs. But I would say that in the context of a toxic drug supply, the need is there and high for virtually anyone certainly anyone using unregulated opioids, given our drug market trends, but even beyond that, I would say. So really, it's a policy failing, isn't it? That we do not have enough capacity here to accommodate the need and the demand, and that prescribers like yourself have to turn people away based on those types of conditions because there's only so much space. So having said all of that, and I'd love to pass it back over to you to kind of expand perhaps on these challenges and barriers, and really thinking about, like, we have this kind of pie in the sky definition that maybe we can all agree about from Kapud about what safe supply should look like. But in practice and application, how does it actually differ on the ground in the current day and age?
Yeah. And I'll speak, I think you just saw me nodding through everything you said there, right? We're in complete agreement here. I think I'll touch on some of the bigger concepts around safer supply first, and then we'll kind of drill down into stimulants a little bit. And I could not agree more with everything that you said about, Kapud versus a medicalized model, right? And I think most of us who are practicing safer supply prescribing, we aspire to the Kapud model, right? And the reality is we live within limitations of the medical model, which is unfortunately the only way we actually have giving people access to safer supply at the moment, right? So I completely agree with the concept of safe. We call it safer, again, because it's in that medical legal model, and we have to acknowledge the risk of injecting any drug. And we also believe in centering, what folks are looking for from their own drug using experience. So it's, at least in London, within the safer supply program, euphoria is actually a goal. It is something that we talk about with people at most visits, right? Whether we're actually achieving the things that they need from their safer supply. And so I think, at least here in London and Kapud, we very much share that common goal, and we absolutely validate it. It's a very important part of what we do. I think, the points that you were making around access, we we deal with this every day. We try to tease it out at every single team meeting because it always feels completely wrong that we're only able to, give folks a safer supply once they've actually meet that threshold of high risk of death, as opposed to, a true public health approach is everybody has it. Right. And nobody actually has to get that far down the spectrum of being so close to death that they finally meet criteria to come into the program. Like, we acknowledge it's horrendous that we're set up that way. And yet with so few prescribers doing it, it's also the current reality that we live in. Right. So it's my genuine hope, and I think we may talk about this later, is that a lot of the prescribed safer supply actually, helps to create a body of evidence that is going to support us into moving into more of a community, cooperative, compassion club, regulated supply model once we generate the evidence through a medicalized model. So Kaput and I share, I think, all of the same philosophy. It's just what I can actually make work day to day in a prescribed model, right? I also agree. One big thing I think is so important to note is another barrier, to when you're thinking about more radical interventions, although it's not that radical, about that need to fail other approaches. And we're trying to pull that out of our criteria here in London, right? Because you're correct. We have a spectrum of interventions for folks, and we shouldn't actually have to sequentially go through them to get to one that can save somebody's life. So rolling that into, stimulant safe supply, we're going to talk about some of the challenges and barriers, intrinsic to that. I think the big one, honestly, is that we actually just don't have a prescribed stimulant that closely approximates the experience of street obtained stimulants, right? So when we're looking at opioids, I do have a wider spectrum that I can offer folks that can give them, if not exactly, a close approximation of the euphoria that they're looking from their opioid of choice. We have a bit more room to play with in that way. We have an understanding of how to push the doses to get to people to the levels that are, effective for them. With stimulant safe supply, the actual prescribed agents that we have, and I'm going to use brand names here specifically. We don't usually do that in talks, but just so that we're all, on the same page. But when we're talking about, Ritalin or Adderall or Vyvanse or Concerta, there's actually a very limited spectrum of options that we can currently offer to folks. And so what I found, practically speaking, is that even if I push people to a dose that, we think should be effective, they're just not getting the experience that they're looking for. And so often we may, use a prescribed stimulant supply to satisfy some cravings, maybe reduce people's day-to-day dependence on having to access a street supply. But I would say most folks still do access that street supply because the euphoria is different. And I think until we get to a point where either through a prescribed model or a community-based non-medicalized model, where we can give people the drugs that they really need, I think that stimulant safer supply is going to lag in its effectiveness in that way. We also, we do have some limitations medically in how we prescribe stimulants that aren't, the same as with opioids. There are some, cardiac side effects or some mental health, usually with people who are experiencing persistent psychosis, where stimulants can worsen that. And because, again, we're in a medical model, that limits the doses and kind of the agents that we can pick for folks, as opposed to if we had a more community-based model. So again, a little bit different than opioids in that way. I think I'm just looking at my notes here. I think I've kind of touched on most of what I wanted to say there. Was there anything that we missed, Nazli?
No, well, I think this last piece, right? You're really starting to get at the lack of prescriber buy-in or possibilities about lack of buy-in because of these types of kind of complications that exist uniquely for stimulants as opposed to opioids. So I don't know if you want to add to that, or we can kind of speak about other areas where buy-in is still needed.
Well, I think that's part of it. I think the potential complications and, the legal requirements that I have to do around, maybe an ECG, which is a heart tracing, or other monitoring, which, medical legally, I'm obliged to jump through those hoops to prescribe certain drugs, and stimulants can be on that list. That can, I think, turn people off a little bit. But also I think it's, we're still only, we've been doing safer supply in London for 6 years. Really, it's only been on the tip of, I think, a lot of prescribers' tongues for the past year or two. And so many, clinicians who buy into the concept are still making that cognitive leap just around opioids. And now we're like, let's do stimulants too, right? And it's not that they're opposed in theory, but I think a lot of clinicians are like, please, we just need to get our head around doing this well first, right? So I think that's time. I'm not sure that there's any other solution to that than time.
Yeah, no, certainly there is some perhaps previous thinking that needs to be undone to accept that and really see the value of that, and drink the drug policy reform Kool-Aid, if you will, and move towards the need for regulation of everything. That's wonderful. No, thank you so much, Andrea. I think you're right. We've talked a little bit about how safe supply expansion in Canada has really been part of the overdose crisis. So of course, there's been less buy-in, I think, from stakeholders across, like from the public, like just, it's way less known, stimulant safer supply. And so there's less buy-in across all levels. And I think specifically including for policymakers. And we've kind of touched on some of the reasons that might be. I think certainly the overdose crisis created the window of opportunity for safe supply. Like so much in drug policy, progress is on after crisis and emergency. Very sadly, those are the things that get leveraged for change or incremental change. So that same window of opportunity for stimulant safe supply doesn't present itself in the same way. And of course, I had said already, and thinking for me, the Center on Drug Policy Evaluation centrally coordinates Toronto's drug checking service. And we know through the drug samples that we analyze that expected opioids, things that people are purchasing as fentanyl, are just so contaminated, not to mention all, of course, very potent synthetic opioids beyond fentanyl, more potent than fentanyl, but also other things, benzodiazepines, synthetic cannabinoids, just the gamut. Whereas the cocaine, for example, that we test is often just cocaine, not including non-drug fillers, but of the drugs that are in it is often just cocaine. And then there is adulterants as well, but there are things like levamisole, phenacetin, still not ideal, still problematic, but not the same kind of risk of like, an imminent opioid overdose from taking it immediately, right? So, and another reason I would say for less buy-in that Andrea, you were alluding to, was just the difference in the evidence base, right? We really do have a significant evidence base, and folks from Canada will be, well aware of the North American Opioid Medication Initiative, NIOMI study. There was also the study to assess longer-term opioid medication effectiveness, Salome. Both of those were looking diacetylmorphine and also then looking at hydromorphone and its equivalency. So those were really, huge evidence base. There's evidence also internationally. So we do have something to build upon it and start to innovate and see what the next kind of iteration is of lower barrier substitution, providing euphoria, all these things, because I think those are starting to move towards that bucket as well. So that will come with time. You said time, and time will require the same thing for the evidence base, as well as kind of changing people's minds, and those would be complementary as well. But another thing I just wanted to say is I don't want to say that stimulant harms are not substantial and growing in Canada, right? I don't want to say that compared to opioids, they're insignificant or something, because they do also play a role in overdose. Like in Ontario, we've seen that opioid-related deaths, stimulants are increasingly playing a significant role, whether it's methamphetamine or cocaine. Many overdose deaths, what we can see in the toxicology is that there are also stimulants there. And this speaks to drug using patterns, people engaging in polydrug use, really high potency opioids needing some sort of legs. So taking stimulants alongside that, right? So for different reasons, folks using these in combination. So definitely there is a response warranted around stimulants because drug use patterns have changed and they're even more prominent than they have been. Yeah, I think I'll leave that little piece there. Andrea, I did want to ask you here about the next steps, really, for expanding stimulant safer supply. Like, where do we go from here? We've talked a little bit about the barriers and challenges that need to be addressed, but kind of what do you see as the future and the direction that we're headed, hopefully.
I mean, I can speak on a clinician level and then a policy level, right? And the policy one, I'll start there because I could rant about this for an entire another talk, right? About responses to the overdose crisis is one of the few fields of medicine or clinical practice where the public has so much say in like what we are allowed to do, right? And so you leaned into it a little bit with those who believe in harm reduction, politically, philosophically, whatever, they can get their heads wrapped around opioid safe supply, because we have had media for the past 5 years saying people are dying, overdose deaths, pictures of folks who are lost in the newspaper. And so people can buy into, I'm preventing death by supporting safer supply, right? Whereas, although there's a lot of stimulant-based harms from the street supply, again, like you leaned into, and increasingly so, it's not in the media in the same way. It's not a public conversation the same way. And so I think the public, which is going to drive our policymakers, willingness to implement, certain allowances of clinical practice, the idea of getting around the idea of like, people are using this for euphoria and we want to make this safer as well. Right. I think it's going to be harder to get policy buy-in in that way. How we get there, I'm not sure. Please, maybe there's people in the chat who can help us with that. But then I think clinically, those of us who are doing this need to make the leap, right? There was a significant leap made with safer opioid supply prescribing. We decided it needed to be done. We jumped in with both feet. We did it as safely as we could within that clinical equipoise, and it grew from there. And so I think those of us kind of who are believing in this, who want to support generating the evidence to push that policy framework, we just need to make that leap. And I'm looking at other clinicians who might be in the audience. I need people to make that leap with me. When we get that critical mass, then we will actually start to get that evidence base. I think, I'm sure we're going to have more discussion here. I am seeing, some questions and comments in the chat around, letting other groups like KAPUT or DOLF, which is the Drug Users Liberation Front, really take this on. And I have to say, yes, please. I couldn't support that more. I think, letting communities take care of their community is where this needs to go. I would like nothing better than to put myself out of business, right? I do not want to be a gatekeeper. I don't want to be a prescribing gatekeeper. This should lay in the hands of KAPUT and groups like DOLF. And so again, how do we generate that evidence to get to the point where community groups are able to make that leap?
Yeah. So important. Totally agree. And I think that's also how we avoid the issues around over-medicalization, right? Is when the individuals that are in the power seat that are putting together these programs, leading these programs, are coming from the community, the people who use drugs themselves. Absolutely. And yeah, I think the DOLF example, folks may be aware about recent work that they've done, advocacy work in Canada, particularly in Vancouver, I believe, in terms of distributing tested and safe, if you will, substances, things like cocaine, and as part of kind of a public awareness raising, trying to shift the minds of people, whether it's policymakers and the public, and they've had some success as well around trying to make some movement for compassion clubs through Vancouver City Council. So maybe that's something that folks are interested in. We can talk about a little bit more, but certainly advocacy, activists, people who use drugs themselves being center and key to that is the way we move forward, right? I mean, as much as we can say that things are moved forward, like those policy windows of opportunity move when there's tragedy, and all of a sudden you have an opportunity and your policymaker agrees with you. This is like decades and decades of grassroots on the ground pushing for this, doing it informally. So that's where it comes from, the groundswell. I think that's the next one.
If you've heard me give a formal talk, I usually end up with some version of everything in harm reduction was once illegal, right? And it's activists and grassroots organizers and people who use drugs on the ground who have actually led it, and then doctors pick it up and pretend that we came up with safe needle exchange, right? When really it's the community that came up with it, and safe supply is no different. I would like nothing better than to put it back in the hands of the community. I will say just one thing before we roll into the questions is, again, please put me out of business and put this in the community. One thing I hope clinically that comes out of this is actually a reframing and a reestablishment of trust with the community of people who use drugs, because the medical establishment, doctors, medical professionals have done a historically absolutely horrible job of that. And I think, bringing safer supply prescribing into clinics like mine, I think has given us that chance to reestablish a trusting relationship, because we're finally actually giving people what they tell us they need and have been telling us for years, right? And so if there's any really positive, medical legacy from this, I hope it's the continuation and building of that trust, even if the prescribing goes back to the community where it should be.
That's wonderful, Andrea. I hope the same for sure. So I guess that brings us to the end of our kind of planned remarks, our little conversation between the two of us here that I hope was of interest and clear to everybody. We're really looking forward to the next half hour or so for taking questions from the audience. So I believe now we'll start to see some of those questions pop up, and I can read them aloud and turn over to Andrea and myself answer them as well as makes sense. Thank you. Okay, I see the first one from Vincent Hesse. Andrea, have you ever prescribed dexamphetamine or diapenon, sorry for the mispronunciation, to substance users? I work with a consultant psychiatrist who estimated 70 to 80% of opiate users present with a history of ADHD, and he prescribed Concerta, which helped to calm down and reduce their I see it here, reduce their opiate use. Thank you, Vincent. I think that's a great question because we didn't talk specifically about dexamphetamine, and that is actually one of the substances you mentioned. There were a couple that were explicitly permitted after COVID and in the guidelines that I put out. So I think that's a great kind of point to pick up on. I'll pass it to you, Andrea.
Yeah. So I agree with the comments here. I typically actually take a pretty similar approach to stimulant prescribing as I do to opioid prescribing, in that we usually do a backbone. So in safer opioid prescribing, hydromorphine or dilaudid 8 milligram tablets, they are the base of the injectable product that we give people for their immediate use, right? For their injection use. Then we also often add a backbone of a longer acting morphine product, something like Kadian or Slan, that'll help, give people legs through the night and in between their injectable doses. I tend to do a similar approach with stimulants, like I said. So a backbone of a longer acting stimulant, something like, again, Concerta or Vyvanse, which you mentioned in your comment. And then with a shorter acting injectable, if people are injecting, right? Typically, we will use the Ritalin immediate release formulation for that. This is anecdotal evidence. There's no published evidence on that. Please hear me when I say all of this. But our users find that those tend to, cook down into a safer to filter and inject product similar to the D8s. And that's why we prescribe them. And so those are the drugs that I typically use. I'm open to learning in this chat as well about what other people are seeing, because like I said, it's still in its infancy with very little, evidence published on it. So I want to hear what you're saying. I would agree with the psychiatrist that you're working with around, 70-80% of people report either, a diagnosis of ADHD or symptoms consistent with that. I will argue, I don't know what's chicken or egg. Right. Often when I sit down with, our clinical ADHD checklist, so many of the symptoms really, are highly reproducible if you're a person who's living in homelessness. Right. And I say that because many, if not most of patients on my safer opioid supply program do live in homelessness or on the spectrum of housing instability. And so again, chicken or egg, are we treating, a pre-existing, ADHD syndrome, or are we treating the symptoms of the social disease of homelessness and poverty, right? I don't know the answer to that. I'm just throwing that out to the crowd for discussion. But yes, whatever we decide on for chicken or egg, it does boil down to the fact that a lot of people do get, relief from those symptoms with treatment.
Thanks, Andrea. Great. Here's one from Naomi. Are you aware of prescription options in other jurisdictions that better mimic the effects of stimulants, street stimulants?
I'm sure not. No. So again, if anyone who is on this session, please pop that in the chat if you're aware of any products, because no, I'm not. No. And that's one of our barriers.
Thanks, Andrea. Okay, here's another one from Jessica. How can we access doctors in provinces unsupportive of harm reduction without risking getting another drug-seeking stamp? Yeah.
Again, if I had, the answer to this $1 million question, right? And unfortunately for Canadians on this session, we all know that unfortunately the country does sort itself provincially into provinces that are more supportive of harm reduction and provinces that are less supportive of harm reduction. And unfortunately, that really impacts access for people who are looking for these things, right? We don't currently have a published network of doctors who could, and sorry, I'm having the chats are all popping up in front of me here. We don't actually have a published list of doctors who are supportive of this approach. We have just very recently launched our national community of practice around safer opioid prescribing. And so we're trying within that to build a network of like-minded clinicians who will offer this wherever they are practicing. And I would like in the future to see that is actually a public accessible list so that you can actually see who might be supportive of this type of prescribing where you're living. We're not currently there yet, but that's a hope. In terms of the actual drug seeking stamp, I just going to put it out there. I take that off every chart I see it on. I think it's a horrendous thing to write on people's clinical records, and we just get the hell out of there. So I don't know how you prevent it getting on there. I'm sorry. Doctors are shit sometimes.
Yeah, no, absolutely, Andrea. And just to add to that, just to name it, because we didn't name it explicitly when we were talking about barriers and stuff, like that's the stigma piece, right? That's the stigma for a healthcare provider dealing or interacting with a person who uses drugs and having their own preconceived notion, that leading to denial of treatment or the services that could benefit them. So yeah, it's an unfortunate but uphill
it's
battle.
a phrase that has such a medical legacy because especially on hospital charts, it just lingers forever. And so God forbid you have a kidney stone and you're a person who uses drugs, right? Or you go into labor and need pain control and you're a person who uses drugs. And it limits so many options. It biases perceptions before people even walk in the room to meet you as a human. So it's just a horrible stamp. So I encourage, again, any clinicians on this session, help me clean up those charts.
I love it. I love it. Practical next step, clinicians. Okay, wonderful. Well, not seeing any more questions in the chat, and feel free, folks, to continue adding them there. We did have a couple of backup questions that I had prepared that I could post to Andrea. So maybe I'll ask Andrea one of those now, and then we can revisit the chat if there are any questions there. So this question was really, I guess it goes back to barriers, but it's for a specific subpopulation of people who use drugs, and about youth here. So I'm wondering if you've been able to prescribe safer supply, whether it's stimulants or opioids in your experience, to young people who use drugs. And if you did, how did that work? If not, what were kind of the barriers at place? I know there's like a parental consent element that's perhaps needed. But yeah, would love to hear about the experience for young people who use substances.
I'll address the parental consent piece first. And so
Sure.
the comments I'm going to make, they're specific to Ontario. So I do encourage you to kind of look up the legal, consent definitions, whatever jurisdiction you're living or practicing in. But Ontario, there is actually no threshold age for medical consent.
Wonderful.
So what a clinician and a patient, what we need to demonstrate to each other is that you understand the treatment or the intervention, you understand the benefits, and you understand the potential harms and the risks. So it doesn't matter how old a patient is, if after knowing someone and having enough conversation with the person, that I am confident that they can articulate the benefits and risks and the purpose and the objectives, I can prescribe to them, okay, without any need for parental consent. We have had a small handful of youth, less than 18, so less than adult age. I would say less than 10 out of 300 some odd folks in London. And they've always come to us from a similar pathway, right? So very street involved, usually living in homelessness, kind of meeting every other criteria of intake to our program. They just happen to be under 18. And so again, we apply that same rigor, to any patient of making sure that they understand the intervention, and then we proceed. So our experience is limited, but I would say, it's not any different than how we would approach any other person seeking a prescribed safer supply.
Wow, that's great to hear, Andrea, that you do have some young people who use drugs enrolled in your programs, and it's not something that you have to say no to or have to turn away. That's great to hear. Okay. one other question I can ask, and I think it's a little bit related. When I was preparing for this session, I was looking through the kind of BC guidelines, and I think maybe that's where I had read for young people that parental consent might be needed in that province. And of course, there's differences. But thinking about our differences across provinces, also the progress that's made in BC, even I think folks outside of Canada might be aware that often British Columbia is a little bit ahead, and Vancouver specifically kind of leading that of other parts in the country in terms of adopting certain interventions, maybe more quickly or scaling them up more than elsewhere. So I wonder if there is if you have some thoughts or some comments around the ways in which that progress on safe supply in British Columbia has impacted the context in Ontario, or how has it not? Or just like a little bit of a compare and contrast and the benefits kind of cross-provincially progress made in both places. Any thoughts or reflections on that?
And I think I spoke to this just a little bit at the beginning of our session. The origins are very different, right? And so the application, especially in some clinics, I think we're moving closer together. But Ontario, safer supply started to divert people who were using the fentanyl-based street supply to a safer prescribed alternative. And the objective was that street supply, right? The public health crisis that we were targeting with Ontario-led safer supply was fentanyl. In BC, the opening of their risk mitigation guidelines, which really was, I believe, the beginning of their safer supply prescribing in the province. It was a COVID-based intervention. So it was still recognizing the harms of street supply, the harms of fentanyl, the overdose rates in British Columbia, but it was implemented to help people socially distance, right? And prevent the personal acquisition of COVID and then spreading to their community, right? So very different objectives. And I think, at least early in BC, I think that impacted how the rollout went. And so when your objective is social distancing versus, actually having people achieve a lifetime access to a safer drug supply, how you intake them, how you wrap around people with supports, your willingness to adjust doses and achieve, actually patient specific goals are going to be different. I think, and again, I'm speaking anecdotally, I think the experience of folks who may have been on safer supply in BC is that it was kind of like, when is the shoe going to drop? When are these risk mitigation guidelines going to expire? Is that going to impact my prescription? I don't know. I think we still don't completely know. And, as the approach in BC has evolved, I think there's some really wonderful, programs like the Safer Initiative and other things in British Columbia that I think, really align with how we're doing things in Ontario. But I think we're still yet to kind of see how the BC experiment in this really plays out, over time.
Yeah, it's just always the ways in which a policy is kind of played out, or the initial aims and the objectives of it, right, trickle down throughout the entirety and the experience of how it's actually rolled out. So we see this in drug policy issues kind of all the time, but making sure that the objectives up the top are as aligned, like not forgetting important pieces like social justice and stuff in those objectives, because when they're omitted, it doesn't carry through. I mean, not to say, of course, progress is piecemeal and incremental, and certain framing, even when limited, is the way to get your foot in the door and to move towards that. But I think that kind of limited perspective is something that needs to kind of be, it's not just a COVID intervention, right? It's much beyond that. And even if I understand correctly, Health Canada's kind of initial, after COVID, their class exemption from our Section 56 that allowed additional kind of prescribing permissions and take-home doses, that was framed as something COVID exclusive. It was set to expire in 2020 and the late 2020, and then it was extended. And then now they still have that. From what I gather, it's just been reframed to be an overdose crisis kind of response, and last to 2026. So they recognize kind of the longevity, but it was, a crisis on top of a crisis, as we were saying before, that motivates some sort of change. And then when you get there, you say, oh, the sky hasn't fallen, and actually this is more useful, and what people use drugs have been asking for decades and want to come to clinics every day, reasonably so. So it's great to see that take those and make them last much longer and keep looking forward to improving them to more closely meet the needs. Oh, wonderful. A question from the audience, from Colleen. Thank you. Andrea, what would you advise other jurisdictions about the role of pharmacists in safe supply, your COVID protocols and otherwise?
I think, my pharmacy colleagues here in London, Ontario, they're some of my closest colleagues in rolling this out locally, right? And I actually think pharmacists are uniquely positioned to actually trumpet the positive effects of safer supply, because especially for the majority of folks who are on a daily dispense model, pharmacists see people every single day, right? Even if I'm seeing somebody once a week or twice a week, the pharmacists see that day-to-day improvement, that day-to-day stabilization of people so much more quickly than I would or any other clinician. And we have a very, flowing, mutually respectful, really engaged clinical relationship with our pharmacists to help keep people safe, right? They do a lot of teaching. We've informed them a lot on a lot of harm reduction teaching. They can, help with, struggles in the moment around substance use. They can, bring back to clinic. They can, maybe alert me when somebody has missed their doses and we're worried about where they are. So our pharmacists have been absolutely integral in, expanding this and trusting as well. And that's where I think, our initial cohort of 25 folks or so, our pharmacists were able to see the dramatic improvement in people's social and health and their well-being. And so that gave the trust that we keep enrolling more folks in the program, right? Because the doses are high. The doses are different than a lot of opioid prescribing. So again, just seeing that incrementalism in people allowed us to expand too.
Thanks, Andrea. Here's another question from Dominique. I'm not sure if this has been mentioned, but many people are accessing their safe supply via the dark web from chemists who have taken it upon themselves to provide these substances, desoxin, under the banner of harm reduction. Obviously, this is only accessible to people with significant privilege, computer, money, ability to access the dark web, but definitely is very helpful for some people. What is your opinion on this avenue of access?
I think I support anything that helps people be safer, right? So I think, any pharmaceutical producer could have, errors in the manufacturing, right? We do actually have, pharmaceutical company level recalls of medications, right? So no system is perfectly safe. And I think, accessing chemists, it's always just a question of, do you know what you're getting, which is the entire crux of safer supply, right? Can you trust your chemist? Can you trust their abilities to make the drug that you're seeking? Do you trust that you actually get what you're purchasing on the dark web? I think that's a really important questions to be asking from there. I think, I've tried to go on the dark web. It scares me. I don't know what I'm doing, but any time that you're, seeking a substance in a prohibition based market, there's always the risk, that you're getting something that the primary objective is profit, right? So whether you're getting a lesser percentage or you're cut with other agents, so no different than street supply, although you would hope to be at a different level. I think I'm circling around this question right now saying, I support any way that people get safer drugs. All of it comes with risk that we need to evaluate from every single source. And so, I just hope that people are applying those same judgments to what they're purchasing. It does come with a lot of privilege. I agree. I always say there's more drugs on Bay Street than in the downtown east side in Canada, right? So those with money are always going to get better, safer drugs, and the dark web will be no different.
Yeah. Yeah, I would agree with everything that you've said, Andrea. And I think the dark web, one of the benefits is that often folks can review sellers, and there's kind of this transparency, historical sales they've made, historical purchases that folks made from them are kind of reviewed, and there's a bit of a track record there that you can refer to that gives folks a little bit more confidence. I think certainly in combination with drug checking services, if those are available in your jurisdiction, or if there's a mail-in option. Again, privilege is all wrapped up in all of this, but if that's something that you can complement your access from the dark, more confidence in what you've purchased, and yeah. So I think I agree.
And these are the things I don't know. I didn't know you could leave reviews. It's like Yelp for buying drugs, right? Is. That's awesome. So, I mean, I'm totally for grassroots and, doing what needs to be done. So I think that's great.
Yeah, definitely an option for those that have access and can often be more in alignment with what they say they're selling, that they are actually
Right.
selling. Yeah. So I don't see any more questions in the chat. I did have one other question that I can pose to you, Andrea. And I guess we started to talk about it a little bit, but it is about this alternatives to the medicalized model. And we spoke a little bit about compassion clubs. I wondered if you have thoughts around kind of how we can move towards a less medicalized model. Like if the compassion clubs model is one that you support and think would work well, of course, being kind of driven by the community, as we talked about, being really important as a central kind of principle of this work. But yeah, any kind of promising, either developing, budding ideas, whether you want to speak to compassion clubs specifically or not, but yeah, ways in which we can have less medicalized safe supply.
So I do think compassion clubs are the next step, right? And we saw this with how, marijuana rolled out and was eventually legalized and regulated in Canada, right? A lot of that did start in the compassion club model, where if not evidence, at least experience around safety was used. And, you see the public and policymakers observing the safety in that model. And then, slowly we work towards, regulated access for everybody, right? And so again, as I said earlier, it's my hope that the evidence that we're generating in a medical model can support the implementation of compassion clubs. And really, from a policy perspective, it means just like not shutting them down, right? And then within those groups, the evidence can then grow to safety and application to the wider population, right? So I think it's, again, as I've said, it's just so unfortunate that, the stigma around this is such that we can't actually just make a leap the way we would investigating any other drug, any other approach, and just, move it very quickly into policy, that we actually have to take this like years and sometimes decades long approach to getting where we need to be, such as the world that we live in, right? And so I can see there's lots of mention around, again, DOLF and compassion clubs in the chat. And, I support everyone, whatever jurisdiction you're in making that leap. Again, easy for me to say. I do have the privilege of doctor in front of my name and, everything that comes along with that. So asking other people to make leaps like that is a big ask. But I think that's, the next step in getting where we're going.
Yeah, I mean, civil disobedience, as you said, everything started out illegal. So all harm reduction started out illegal. So certainly that plays a massive role here. And I think, being championed by groups like DOLF. And that, there's been some great stuff in the chat noting that DOLF, they do themselves purchase from the dark web, small amounts, and then have those tested and then purchase larger amounts. I had said cocaine before. That's not the only substance that they distribute through their advocacy. Heroin and meth, I believe, are the other two as well. So certainly some really important work happening on the ground and demonstrating like what it could look like, because I think it's one of the things we have in Canada is that everything starts through pilots, and often, sadly, we also get like stuck in pilot projects and like the pilots forever, or they don't get sustained afterwards. But that often is the first way, and then there's this process to keeping it going, keeping it sustained. So for me, when I'm thinking about something like the Vancouver City Council being supportive of compassion clubs and asking for exemptions to move forward with that, like that would be a really incredible pilot, quote unquote, or a model that see how it works. People look at it, get more comfortable, start to get that buy-in, and then move towards expansion as it becomes less fringe, and it becomes more seen as
we are not going to get through this with prescription pads, right? Even if we could, we shouldn't. This should not be a doctor-patient relationship, right? This should, I get whatever I want from the LCBO whenever I want it. The same should be true no matter what you choose to consume to, achieve the effects that you're looking for. And I think it's important for people listening to know that, myself and my colleagues who have been doing this for a bit, every single policy meeting, every single political meeting that we have, most media meetings, although they usually don't write it, we'll say that compassion clubs is where we need to go. right? Please take this out of our laps. Please help us take it where it needs to be. And I think those of us, again, in my position, and kind of, people have been doing this for a number of years, we stand in solidarity and support of groups like DOLF. And if there's any way that we can assist you, if there's any way we can stand beside you in allyship, is there any way we can use our privilege and our voices to take that to the next step and where it needs to be, please let us know. Okay. We do not want to run this show. We want to stand side by side with the people who should be.
Mm-hmm. Mm-hmm. Andrea, that's really a kind of a touching place to perhaps leave any additional closing remarks you have, or any other thoughts. We have no more questions in the chat, and I've gone through my prepared questions. So maybe I'll ask you for any last kind of thoughts and closing remarks beyond what you just so eloquently shared, and then maybe I can make a brief closing remark as well. And unless another question pops up, we may have time for one or two more if they show up in the chat. But yeah, Andrea, any last thoughts, things you haven't said that you want to make sure you say? Or have you covered it? No pressure.
No pressure. Yeah. We've touched on most of it. My other thing, clinicians, if you're in the audience, just do it. Pick one person, pick two people, pick 5 people, and just start doing this. Mm-hmm. We need people across the country, across the world, to just take that leap and start doing it, and create that critical mass, to create that body of evidence, to take it to the next level.
Mm-hmm. Absolutely. That's great, Andrea. Maybe one straggler thought that I will share in terms of my closing remarks, because much of my work around drug policy is at the United Nations, and trying to support our Canadian government to take more progressive positions at the UN in front of other member states, kind of share what we're doing that may be beneficial elsewhere, kind of best practices we've developed. We still have a lot of work to go, but of course, there are countries that are much light years behind us when it comes to harm reduction, and safe supply is nowhere on the radar whatsoever. And I'm really happy to share the last few years, the Canadian government has made really strong, supportive comments around safer supply, standing up in the plenary and General Assembly for meetings of the Commission on Narcotic Drugs, and sharing kind of all the benefits of that. So it's not something that they're kind of sweeping under the rug, or sometimes with certain things that, they kind of wash their hands of it and say, oh, this is just something that these stakeholders are doing or piloting. But of course, it's something that they funded. And of course, it's something that we've seen them really kind of championing and speaking about. Now, there's of course the piece of holding them accountable. It's one thing to wave the flag about how you're doing safer supply in your country when there are so many more people that could benefit from it that don't have access. So it is also kind of a point of leverage for us to say, well, if this is something you're very proud of, let's continue to improve it and make it better, and give a model that others in the world, as you yourself are recommending, could perhaps look to. Not that they're saying Canada never stands up and says, do what we do in Canada, but they, I think the point of sharing is to perhaps give some ideas to others, particularly those that are affected by similar kind of drug market dynamics and trends that we are, although I think regulation would be applicable worldwide. So I guess maybe if there's no other questions in the chat that have come up, and I see some thank yous, very, 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 very thankful to Andrea for me. Couldn't have done this without her. She's the expert on this topic. Really happy to have been able to have this discussion with her, and hopefully added some little policy nuggets and pieces that were maybe relevant as well. And yes, thank you so much to those that organized this. I hope that folks enjoy the rest of the Constellations Conference. It's packed full of really interesting sessions and wonderful speakers and experts and people with lived experience of using drugs. So I think, lots of good pieces to attend, and I hope you all will. And I thank you one last time. Have a great rest of your day, everyone. Thanks so much.
Thanks for welcoming. Have a great day.